Hi, everyone. My name is Scott Allen. I'm the CEO for the Family Medicine Education Consortium. So welcome to tonight's Hot Topic webinar. We're excited to have you and hope that we have some great discussion and interesting presentation from Bayhealth Family Medicine Residency program tonight on community leadership and advocacy. So I just want to make sure everyone knows a little bit about the FMEC. We are a regional coalition of family medicine residency training programs and medical schools. We have 14 states and DC in the Northeast US. And that has about 190 family medicine residency training programs in that region. We do an annual meeting each fall, which brings about 300 medical students on scholarship to the meeting to learn about family medicine and learn about primary care and to meet the residency programs. And we also have hundreds, 250 sessions and posters through the course of a weekend. So it's a very busy meeting, very exciting, coming up in about 2 weeks. We also have a series of awards we give to family medicine physicians and others who are supporting primary care. We do some learning collaboratives. We're doing one soon around hereditary cancers in women. We have one on integrative health, and we're hoping to do one on obesity soon. And we just love to have people volunteer and help out with what we do. We are a catalyst convener and incubator. Our job really is to promote family medicine and primary care to medical students and pre-medical students, support residents as they gain presentation experience, learn how to transition into a career and decide what kind of career they want. And we also help connect family medicine residency training programs together so they can learn from each other. So with that, I am going to turn it over to our speaker tonight, Dr. Samuels from Bayhealth.
Yes. Hello, everyone. My name is Dr. Samuels. I'm one of the Associate Program Directors at Bayhealth Family Medicine Residency Program in Dover, Delaware. And I'm also joined with Stephanie, our lovely Program Coordinator. So thank you all for taking the time out. I know it's late, especially since we're all on the East Coast. So I know some of you still have your classes that you're in or different rotations that you're on. So again, thank you for coming tonight via Zoom. So I did want to start first with a little bit of our program overview, and then we'll talk a little bit about community and advocacy and what that looks like at our program and what it can look like in the broader sense as a physician. So some of you kind of missed my little disclaimer earlier that I use WebEx at work. So whenever I switch over to Zoom, it's always like, why doesn't she know how to use this? Because the rest of the world has been using Zoom for 2 years. But I will share my screen. And then, yeah. No? Almost. Yes. Okay. All is well? Okay, thank you. Okay. All right. So again, this is our general overview, our program overview of us. So this is Dr. Vasagar here and Stephanie, and this is the internal medicine program director, Dr. Deutsch, and this was their coordinator, but she has gone elsewhere now. This is an incomplete picture, so we need to get some new pictures of who we all are. We have a few more faculty members, but again, this is Dr. Vasagar. Can you all see my pointer too? Okay, great. This is Dr. Vasagar, again, program director, and this is Dr. Siegelman. So he's the designated institutional officer. So we all kind of answer to him. And Dr. Prabhu is the other program director, associate program director. That was Stephanie. All right. Oh, was Sue in that picture too? I can't see. Oh, and there's Sue, right there. She's our behavioralist. Okay. Behavioral therapist, and she's been a great addition to our program as well. And we'll talk a little bit more about her involvement in the program and that also contributes to that community and advocacy as well. So generally speaking, a little bit about our interview day. We'll have some Wednesday sessions beforehand, and then we'll do our interviews, 4 sessions for each one. But that's a little bit later, so we'll talk about that. So a few things about, again, we're in Dover, Delaware, so we're a brand new residency program, 8, 8, and 8. First class began in July of 2021, and we currently have some new interns who just started, so we're excited that we're continuing to grow. We do have a full broad spectrum, inpatient, outpatient, urgent care, geriatrics, pediatrics, and obstetrics. So I am FMOB, so I do deliveries as well, vaginal deliveries. And we do have Dr. Verdi, she's our geriatrician. So she also helps with that as well. And then we do have our unique curriculum, which really is that advocacy piece that really sets us apart. That is something that we're really proud of. So I won't read the whole thing here, but basically our vision statement is to train family medicine physicians to be the best possible advocates for patients. And I think that's really important in terms of that physician advocacy piece, because in a lot of ways, sometimes people feel that, oh, as the physician, I'm just here to address the clinical needs of the person in front of me. You know, your A1C is, let's say 10, let's get you better controlled. I've done my piece and I'm done. But that advocacy piece is, all right, what are some of the barriers or limitations to why that person's A1C continues to be above goal, continues to be above 9? Are they having difficulties getting nutritious foods? Are they having difficulties purchasing their insulin if they need it, or their medications? What other things can we do to help support our patients? And that's really where that advocacy piece comes into play. Again, another picture. So we're missing a few people. So like I said, there's Dr. Verdi, who's our geriatrician. We also are missing Dr. Debo. She's our medical director, and we're missing Dr. Bachech, who recently joined us, and she's more of our research geared person helping us with our quality improvement programs. And another important piece, which again is something pretty unique to our program, that we have a clinical pharmacist embedded with us in the community. His name is Cameron Golden, who's a PharmD. So he's been extremely helpful in terms of sometimes our patients come in, it might be a new appointment and we're trying to do the med rec and they may not remember their medications, they may not have brought them with them, their medications, or if they do, they're not sure how they're supposed to use them. But we can say, okay, come back and have that appointment with Dr. Golden, and he can really reconcile the medications to say which medications should you take, which one shouldn't you, what are some concerns for polypharmacy, what maybe can we work on deprescribing. So he's been a wonderful asset to the community as well, especially because we have for our older population, he's been really helpful to answer some of their questions too. And that also allows us time to continue moving along with our patients as well. So that's been wonderful. Again, it's not just the core faculty members I just described. It's everybody who's involved with the education of our residents. We have ER physicians here, we have surgeons here, pediatricians here as well. We won't go through and name who everyone is, but just that it's a team who's involved in educating our residents. And this is what a typical block schedule would be. So one thing that we are excited about too is that we do have that whole block. So in July, everyone has that focused orientation to again, kind of let everyone know about our program, the expectations that we have, how we're involved in the community, and just go over some of the basic things of how do you do sutures, or, we have our simulation lab that I think the official open house was this past week. Yes. So the official opening was then. So we've used it for our residents. We do the also course there. So advanced life support in obstetrics. So we do that there with the high fidelity models. Some of the surgery residents as well use the sim lab. So, state of the art, that's something we're really excited about. So a lot of those things happen during that orientation week. And then you can see the internal medicine, the OB block, peds inpatient, ER, more internal medicine, and community medicine, which is the important piece for our program. And I think, again, this kind of lays this out again. Let me see if I can move you all so I can see myself better. Okay, the screen better. So yes, so that community medicine that you have during that first, your PGY 1 year. So with that rotation, you really just kind of go through and see what is available in the community. You rotate at the homeless shelter, you rotate with the FQHC, more Medicaid patients. You rotate with Camp Rehoboth, so that's the LGBTQ organization closer to Rehoboth Beach, and kind of help with those patients and what their particular needs might be. And really, you can think of it as a introduction to the community, kind of like a fact-finding missions. Like, what are the needs of the community? What are they telling you? Not necessarily you're saying, I think you need this. It's no, you've been with them, you've rotated with them, you can see what their needs are. And then that second year, you do that community research and QI project. So that's when you're able to say, okay, I see that at the homeless shelter, they had a real need for the women there for their sanitary pads and things along those lines. So how can you develop a project to kind of bring more of those things there? Is it that you're going to work with other community organizations? Are you going to do drives to kind of bring support there? What other things does that organization need specifically that you can help them with? And then that third year, when you get to the community leadership, and advocacy. So that's really when you're bringing it all together and saying, okay, we have this homeless shelter here in Dover, Delaware. We've worked with them. We've addressed some of their needs. Again, the example being sanitary napkins that they might need. And now we're going to go speak to our legislators about how can we really secure this funding to where it's not just in-kind donations are the only way that they get this resource. What are some other strategies that we can do? How can we advocate on behalf of this organization to make sure that they have what they need? Or is it increasing anal PAPs in the LGBTQ community? How can you educate those people? How can you educate better the community resources to say, hey, you still need this, this is here. How can we make sure people are aware of PrEP in the community? So that's really what that third year is focused on, is really putting that legislative piece into what you've been doing and familiarizing yourself with that first and second year. You've built that relationship with that organization. And then again, we'll talk a bit more about that, but this is just the campus. So 2 campuses, Kent County, which is in Dover, and then Sussex, which is in Sussex, but it's a bit more rural in that area of lower part of Delaware. So Delaware is small. I think most people know that. We only have 3 counties. So Kent is in the middle of the state, and then Sussex County is in the lower part of the state. So just 3 counties. And then obviously we've already opened June of 2021. We have 4 practice rooms, again, state of the art because it was just built, and really increasing those patient volumes, the variety of pathology. So what you will see for some patients is different. Some of it has been in the community. They're kind of I would say our patient base is varied. So we have some patients who are there, you can think more like farm communities. You can think, so there is, I'm drawing a blank, but there are 3 chicken farms in the area. Purdue.
There might be more, but the companies, yeah, Mountain Air, Purdue, and there's one more.
Yeah,
can't think of the name.
Right. And there's also Kraft Foods is also located in the community. So that kind of shows you, and we do have some Amish people as well. So some of the different needs that they have might be a little bit different. Then we also have a lot of people who have retired from New York or New Jersey who relocate to the area. So a little bit different in terms of their healthcare needs, but we're still here to support everyone. So you're able to see a lot of different things. And then that other piece that I was mentioning in terms of mental health and counseling, we also do MAT. So we have Suboxone as well for some of our patients if they need it. And I have a few patients who have come in who've been thankful that we do offer that because they feel less of the stigma associated with going to a methadone clinic if they know they can come to the practice with us and we can prescribe and kind of continue on. Like I said earlier, we also have Sue Chafin. She's our licensed therapist, and she's been really beneficial in terms of the warm handoff. If somebody comes in and they're maybe in a mental crisis, she's available and can talk to them, and then we can have them schedule with her to kind of do that therapy component, because we know that we don't necessarily have the time to hear all about the details of their struggles, but we can help with, do we need to increase your Lexapro, or are you ready for medications? Do you just want to do therapy? That piece of it. So Sue has been very helpful with that as well. And then this is a rendering. She had a real picture of what the building looks like, but this is a rendering of our building. It's pretty true to form, looks like that. Offices look a little bit like that. And then again, this is the space. This is just the blueprint of where we are, which, you know, when you come, you just work where you work, but it looks pretty. All right, so again, the unique programming. So that again goes back to that community medicine piece. So again, that Camp Rehoboth that I was referring to earlier, also the Delaware Veterans Home as well. So there is Dover Air Force Base. So we are able to really address some of the needs of the military family as well. So we can see, okay, how about the transitioning in terms of relocating for some of their military service members, and really those retirees or people who have retired from the military, stay in the community, and helping them bridge that medical gap as well. And we just picked up a contract with them as well to be one of the providers for their pediatric care. So that's been really helpful. LaRed is an FQHC, again, think more Medicaid patients, primarily more Spanish speaking in the lower part of the state. And then West Side, again, also is a FQHC, not too far from where we are. And then West Side, they have their van, their mobile van, So it's seasonal. So they do go to the migrant farms or to the farms and then work with the migrant farm workers there. Again, you get to see a little bit different pathology, TB, things like that, that you typically would just read about, but you're able to, again, work with patients in that way because we have the van and we want to make sure that the residents come away, having a more complete picture of what community medicine looks like and what being a family physician looks like. And so again, that's where you're able to do that advocacy piece as well. And then like I mentioned, Sue, she's here to help us with our wellness. And these are just some of the benefits of the program. And then just a bit more about why us. First residency program south of the canal, you'll have a voice. Nonprofit, and we're really excited, and that is true. Bayhealth really is supportive of the program and us being involved in the community. And that's our contact information. So I am going to stop sharing and pull up something else for me.
While Dr. Samuels is doing that, if you choose to interview with us, you will get to meet the residents and they can tell you about day in the life and, you know, what they're doing there and how, and their experience in the community medicine rotation, because they rotate through a lot more services and a lot more community partners. So it's just, it can be what is of interest to you or just going through what we have set. So it's your oyster, right? Like when Dr. Samuel said, you can have a voice, you'll hear from the residents a lot saying, oh, we definitely have a voice. Like we've changed many things according to what they have said. We can't change everything because we have to make sure that we're in standards and stuff, but we're very open to feedback.
Thank you. All right.
You got it?
Yes.
Oh.
No, that's good. That's good. All right. So kind of moving the next step forward, right? So in terms of, this is our program, this is what we focus on. So then I did want to speak a little bit more about what does advocacy mean to you, because that can mean different things to different people. And for some people that is a very exciting thing of, yes, I'm going to go out and, you know, fight for my community and speak truth to everything, right? And other people, it's like, oh my goodness, I don't really want to do that. I don't really want to be that forward. Might feel a little nervous or skeptical that your voice is going to make any change at all. So I think an important piece when you think of advocacy is that you have to have kind of like a short-term view and a long-term view. So in the grand scheme of things, yes, if you were saying you wanted to advocate on that state, local or national or even international level, you're looking for most likely some law to be changed or introduced. That takes some time, that takes some relationship building. But in that small piece, the relationships, and that's one thing that we're really excited about. So yes, Delaware is small. We also have a really active Medical Society of Delaware. So they do have a lot of legislators come in and I'm drawing a blank, but it's kind of like a sip and meet where you can have, where they bring the legislators in and you can truly go have coffee with them and talk about the things that are concerning to you, to your patients, and kind of advocate further. So we talk about this with the residents, and this is going to seem like almost too good to be true. So I am simplifying this a bit more, but I think it really speaks to what advocacy can look like in Delaware. So I live in Newcastle, Delaware, so that's one of the again, I said only 3 counties. So I live in the northernmost county. So while there, you know, I met another physician and she said that one of her, and I'll admit that this is a bit more of an affluent area where she's referring to where she works, but a patient basically had been not let go, but his primary care physician had retired. So he was looking to establish with a new primary care physician and he called her office and her office told the patient that unfortunately she was no longer accepting new patients because she basically was already overpaneled in terms of the max amount that she could see and really address their medical needs. So that person, that patient, didn't like hearing the answer that they couldn't establish with her. And so they went and spoke to their legislator to say, hey, what is happening here? When I'm calling, trying to get a new appointment, I'm being told that no one has availability for me. So then in turn, that legislator called the physician to say, I got a call from my constituent saying that they could not make an appointment with you. Is this true? You are a recipient of, because this is the mindset that the legislature had, you are a recipient of funds. You have said that you're accepting these patients with this health insurance. Why are you denying these patients care? And thankfully, and this is where kind of being involved and being able to kind of speak to your own needs and desires, right? She was able to say, well, one, she's over paneled, and two, the reason why she can't see that patient is because a lot of physicians in the neighboring community have been retiring or changing over to concierge medicine. So that conversation was able to lead to another conversation in terms of, well, why is that? And she was able to talk about, reimbursement rates, and the various needs. She was also able to talk a little bit about prior authorizations as well. So it really kind of brought in this whole conversation that truly started with somebody being upset that they couldn't establish care with her, but that led to them really collaborating a bit more on the medical needs in that area and that legislator's district, of course, to start with. But it led to a broader conversation. And a part of that broader conversation did discuss, and it did kind of bring in for more collaborators with the Medical Society of Delaware, the Delaware chapter of the AAFP as well, and a few other stakeholders that kind of all collaborated to say, well, what can we do to kind of stem this flow? Not to say that there's anything wrong with doing concierge medicine. If it works for you, great. But when you do that, there tends to be a population of patients who no longer have a physician. So what to do with those things? So another part of that conversation, that collaboration, and again, that advocacy piece was that she was able to also partner with other specialists, because not only was it that she and the others weren't able to see new patients, it meant that for those patients, they were then asking their specialists to do things that I won't say was outside of their scope, but if you are not pregnant, does your OBGYN really need to manage your blood pressure? Most would argue no. But if they can't establish with the primary care physician, they're going to do their best. So through bringing in the voices of the specialists, they were able to say, okay, we need to change the reimbursement rates here in Delaware. We looked to the north, to Rhode Island, to get some examples of another small state to see what they're doing. And it did become the primary care bill. So they wrote legislation and actually changed it to get better funding, better reimbursement back from the insurance companies in Delaware. And again, this involved a lot of people, and a lot of this stemmed from that one patient who wanted to establish care and was unable to do so, but two, that primary care physician, that family medicine physician, being ready and being able to advocate not only for herself, but also truly on behalf of all of us as family physicians in the state, because the reimbursement rates really affected all of us. So I think that's a good example to kind of highlight what advocacy means. It's not just, that as a huge example and a great win, and that took time, right? So that wasn't just, oh, the phone call I can't establish with you, and then 3 months later we have a bill. That took a few years to get that going, but it was still a good process that involved many people and a lot of no's, because, as great as it seems, like, okay, well, yes, increase the reimbursement rates for the family physicians, so maybe less will switch over to concierge, or maybe they'll be able to see more patients. There were some people who didn't like that idea. So having really to have many sessions, speaking, a lot of things, going up to the Hill, our version here. So those are different ways that you can think of advocacy on that kind of state, local level. And I think another time too, when you think of advocacy, just also too, another example is at the hospital, like where you work. So let's say that you're all medical students and you notice that your patients come to the appointments late, and they are always late. Well, why are they late? Is there a shuttle issue? Is it a transportation issue? Is it something that you all can advocate to say, hey, I'm using our local bus system, is called DART. I don't remember what it stands for, probably Delaware something, but it's called DART, it's the bus. So is it, hey, DART, can you have a bit more drop-offs for the hospital than you do the other routes, because that would better assist our patients? Can you make a new route? And while that sounds like, yes, everybody would say, yes, we will, to get your patients to the office, but that also involves who is the driver, who's going to do that? Is there more maintenance involved? Because now that bus transportation, whatever they're doing, is going to cost a little bit more. Gas is not cheap. We all know this. So it involves a little bit more, but that's still part of that advocacy piece that you're doing. And so I think a lot of times, sometimes we think advocacy has to be really big and large, but it can be small. It can be for the community, and it can be, again, at that national level as well. Student loans, we all have them. So again, still that piece of it. So I did want to pause here just to ask if anybody had any specific questions, or if anybody is working on something even now, or has gone to, on the Hill days in your areas.
You go ahead and
Still waiting.
unmute yourself if you want to ask a question. Go ahead.
Oh, Raphael, yes.
Yes. Hello, and thanks for having us tonight. I really like the way Bayhealth system works through the community and have a big community outreach. In terms of faculty and mentoring, what is the program philosophy related to it and related to the residents? Could you tell me a little bit, please? And thank you.
Sure. So two different things. I think a lot of times we kind of use the words advisor and mentor synonymously, but we do separate them here. So every resident has an advisor, mandated, ACGME requirement to kind of help you move along and graduate. For my advisees, my responsibility is to make sure you're meeting your numbers, you're doing what you need to do. We can all graduate on time. Great. So when it comes to your mentor, that's where you say, okay, somebody who has a similar interest that you have. So we have one resident who's really interested in administration, hospital administration. So for him, his mentor is Vice President of Safety. Is that Dr. Fink's title, Stephanie? Very similar to that. We'll say that for now.
Yeah, it's like quality, patient safety and quality improvement.
Yes. So, thank you. But because we know that the resident has that real administrative bend and is interested in that, they're a great pairing together. So that mentor piece will kind of help a bit more with the nuances of your particular interest in medicine. Whereas as the advisor, I'm here to make sure you can have a job at the end of this because you graduated on time and did what you need to do. Does that kind of help answer your question a bit more?
Yes, it's okay. Thank you.
Sure, no problem. Okay. All right. So we will kind of continue on. So, all right. So another thing too, and these are real world examples, some of them happening even right now. Oh, don't lose my document. Hold on. Move it to the side. Okay. All right. So I'm not sure how many of you are familiar with the nuances of Delaware, probably very few because Delaware is small, but we do not have a medical school. So we are one of 4 states that does not have a medical school. Now, to our neighbors all around us, Pennsylvania, of course, has medical schools, New Jersey, everybody does except us in the East Coast. The other being Alaska, Montana, and Wyoming. I think it's Wyoming that doesn't have one. Medical schools, all of them have residencies, but medical schools. So there's been a lot of talk over decades to say Delaware needs a medical school. How can we make this happen? I won't even call them false starts, but just conversations that kind of pop up from time to time of we should have a medical school, and then it kind of falls flat for a variety of reasons. So most recently, there was a conversation last month, let's just say last month, or over the summer, but I think it was last month, where I opened the newspaper. I know, newspaper, but I still looked, and there was an op-ed from the Newcastle County executive, kind of like the county mayor, so to speak, making the case for why we should have a medical school in Delaware. And I thought, whoa, this is very, this is a very bold place to put this, to say we need a medical school in Delaware, to make this full op-ed. And then I realized he was also kind of making the circuit. He was on the Delaware Public Radio, again, advocating for the need for a medical school in Delaware. And I thought, oh, okay. And then again, Delaware's small, so relationships are easily made. I also noticed that he was mentioning a few of the physicians who I'm very familiar with as well, and saying that looking to them as examples of what we should do and why there was a need for medical school in Delaware. And again, still I'm thinking, oh, okay. And then, this is only September 1st. So then in August, there's another news article that says one of the healthcare systems and one of the local universities is now in discussion about a medical school in Delaware. And so I thought that is a prime example of kind of that advocacy piece, getting who your stakeholders are. So do I think that all of this magically happened after that op-ed? Of course not. This was obviously something that was in the works, but that op-ed piece kind of speaks to the need to communicate your desires, communicate your goal. It doesn't necessarily have to be on such a large platform of an op-ed and then you're on various NPR news stations, but what is your ask, really? That's the first part. Knowing what you're asking, who are you asking that from? If they say no, like what your next step is too, but really, what are you asking them to do? Is it just, oh, I want to engage the readers to say, yes, we do need a medical school. Okay, but then are you asking the various healthcare systems and the universities, I think we should have a medical school because it will do this for the community, and it will also help your school in terms of the, so to speak, prestige of your school by saying you have a medical school as well, the financial impact of that as well to the school and the community and all these things. So figuring out, you know, for the different stakeholders, what you think will move them, what is the emotional story that you can also say when you're really advocating on behalf, in his case, advocating on behalf of the whole state to have a medical school, but let's be honest, he's the Newcastle County executive, so it would probably be in Newcastle County where he would have the medical school. Not to say it can't be elsewhere, but if he's the one who's making the argument, that's probably where it would be. And then that also goes to say helping his constituents as well, helping the residents of that county to be able to say, oh, look at all the improved healthcare that we're going to have because we've brought in this medical school. We're able to retain the physicians who graduate from this medical school. They're going to stay here into our healthcare system that we already have. Look at how beneficial this is to us. So there are a lot of arguments that can be made for that. And I think it's a really good example of advocacy from his standpoint, but also for physicians as well, advocating that, yes, we do need a medical school, and the conversations that are going on, you know, aside that as well. And then in terms of, I think sometimes too, you know, especially when you're a medical student, and as you continue on with residency as well, when you're thinking of what your ask is going to be, what thing is it that you want to change? I think sometimes we're really fired up in the beginning of, you know, I want my debt to be forgiven. I want all of my student loan forgiveness to just wipe away, right? But probably not going to happen all of it, but some of it absolutely on its way, but not all of it. But one of those pieces in terms of advocating for yourself with that would be, is there already an organization that's working on that? And I use that as an example because we all know the answer to that is yes, right? And so they're able to all come together and collaborate behind that one unified message. So we know the AMA has things behind it, AAFP has things behind it as well. Different state and local agencies have things behind it as well to kind of move that discussion forward. So when you're thinking in terms of whatever the piece is that you want to advocate on, who are your other stakeholders, or is there already work being done in the community with that topic, and how can you kind of join forces together, collaborate with them a bit more to kind of move your discussion forward? And that might mean that you necessarily can't be extremely rigid on what it is you're asking. It may not line up 100%, but if it still can move it forward for you, then that's something that you should consider, right? You don't need to recreate the wheel. So again, you don't have to recreate the wheel when you're thinking of what your ask is and who's going to help them. And also you want to try to provide a solution for what it is you want to do as you're advocating for others. So if you can, and this is where that piece of data comes from, to say, again, this is going to go back to another discussion we had earlier, but if we were going to say, yes, we need to do, I'm trying to think which one I want to go with. Actually, I'm a different example for this very reason. So if we said, oh, we have higher rates of ovarian cancer in the community, how can we advocate on behalf of women to say, this is what you should do to prevent ovarian cancer? If you wanted to start with the patients, it might be that you decide to advocate and really change it to be more on medical education for the physicians you're working with, to say, let's know the signs a little bit better, improve our medical knowledge of ovarian cancer. And maybe that can be part of how you're advocating for your patients as well. Another piece with that is thinking about, you know, dollars and cents and getting the data. So if we have higher rates of ovarian cancer, can we think of maybe why? Is it because people don't know what the signs are? Is it because we don't have enough physicians in the community to be able to address them? Is it because people have to wait so long? Again, still going back to that need for more primary care physicians to come in. Can we advocate on that piece? Different things. So even when you're thinking of advocating and your ask and your data and all of these points, you still want to kind of end with a story when you're advocating for whatever it is. So that story can look like, I have a patient who came to see me, who she had been in the hospital for something unrelated, and she had a vaginal concern while she was there. They did an ultrasound. It wasn't a good result or reading, so they said, hey, come back. That's not really what you're admitted for. It's not for your GYN concern. She comes to see me, and I say, oh, okay, this is abnormal. Please, let's move on. Let's get an MRI, and we can move from there. After much pathology, and not pathology, but biopsies and having to transfer her out, yes, you do have stage 4 ovarian cancer. So that is part of those stories. And I picked her for an example because at any point of what I just mentioned could be a piece to advocate, right? So we could say we need to tell women in the community, these are the signs, or we need to say, how can we help make sure we do we need to do community fairs where we're doing more women's health fairs in the community to say, if you have this sign or this sign, please make an appointment. Can we do a community fair and say, please make an appointment with whom? Is there availability in the community with the physicians, or is there somebody else they should see? So there are different steps that you can think of when you're discussing or thinking about what is your ask, who are your stakeholders, what's the data, different things to consider when you're trying to advocate, because it can come in at different points. Okay, any questions about any of that? I know I said a lot. Okay, well, I did want to keep it kind of general enough, but with some examples of things that we're actually doing at our program and how that community medicine is working through. We do have a few residents, and again, we're only in our 2nd year, so I don't have a finished product all the way to say, this is what our resident has done, to kind of state the obvious. But we do have some residents who, through the community medicine different rotations, have said, oh, some of them want to work more with CP organizations, the organizations that help patients with cerebral palsy, who are a bit more high functioning, to say, instead of being somewhat isolated in where they are, they can maybe have different memberships at the YMCA, and not just Easter Still, but different areas to have them really participate more in the community. So that's something someone is interested in. Another person is interested in anal PAPs as well with the LGBTQ community, to kind of see how they can increase screening to then decrease the rates. A few patients, or excuse me, residents are interested in PrEP as well in the community. Again, still going back to LGBTQ. And I did want to point out one thing too. It doesn't have to be community facing in that way. It doesn't have to be state facing, and what I talked about earlier. You can advocate even within your own institution. So one of our residents is also advocating on the electronic medical record system that we use, and having it to where a person's preferred pronouns can be displayed more prominently, and not have to click away, but that you can say, yes, she, hers, or they, them, so where those gender pronouns are more prominently displayed. So that's advocating as well, to say, who do you need to meet with? Is it the IT people? Is it somebody else? How do you make that change? And to who is going to benefit from that? So there are different ways you can advocate for others. If there aren't any other questions, I don't know, Stephanie, if you had anything else to add.
I had a quick comment and question. Sorry. Thanks, Dr. Samuels, Ms. Green, Mr. Allen. So I've been doing my clinicals across Pennsylvania and New York State the past 2 years, but my permanent address is in Florida. So this past AAFP Advocacy Day, I was one of the students to go to the Hill. And what I found was that even though the AAFP is this huge organization, I feel like we're not getting a seat at the table. I think they were saying this was the first year that we had hired like an outside lobbyist group, Advocacy Associates, to schedule our meetings on the Hill. And I found that we were just meeting with legislative aides and legislative correspondents. We had maybe 5 meetings, but we never actually got through the actual person. So the fact that you're saying that it takes time to build a relationship, to cultivate a relationship, I think that's definitely true, because as family physicians, we're tasked with so much, but without that advocacy piece or that public health piece, we're leaving so much on the table in terms of like patient-centered care. So just wanted to say thank you for, having this perspective. I haven't really come across anything like this in medical school or my rotation so far.
Well, thank you for that. So I did participate. It was through the AMA. There are medical students on the Hill Day. I don't remember if that was the exact title of it. It feels like ages ago, but I did go. And I kind of left that with two things. One, feeling like, of course, it's the AMA, so they had like a well-oiled machine when it came to who your legislator is. These are the talking points. It was very well organized. You know, it just was from top to bottom. But I still ran into the same thing that you experienced, where we were meeting with staffers. And initially I thought, well, I mean, that's great that I'm meeting with the staffer, but I came to talk to, you know, my legislator. That's who I wanted to talk to. I've done a couple on the Hill days, again, in DC, and then a few others. I went to medical school at Morehouse in Atlanta, so we did a couple on the Hill days there as well. And through doing that, of course, I've been active in Delaware as well. Again, Delaware is small, so it was a little different. But in those other spaces, you do realize that the staffers in some ways can be exactly who you need to meet with. Because if you're able to meet with their health policy staffer, you are, in a lot of ways, speaking expert to expert, where they're able to say that is their area of expertise. They're responsible for the funding. So they may tell the legislator, I can't think of her name, but I was going to use a more national example, but I'll speak to Delaware. So Lisa Blunt Rochester, right? So she is one of our representatives. Do I expect her to know everything about everything? No, she's our representative. She needs people, an expert to help her. So if I have a question about healthcare, I want to speak to her expert because that person actually knows what I'm saying. She's going to rely to her expert anyway, and her staffer regarding healthcare and health policy. That is who I want that relationship to be with. If it can be with Lisa Blunt Rochester, that's wonderful. But I know that anything I bring up, she's going to run it past her health policy expert, her staffer. So that in some ways is who I want to talk to. I mean, obviously meeting with your state legislator is great for a lot of reasons, but when it comes to who is going to know exactly what you're talking about, exactly what bill, how it's funded, the different appropriations with it, who's the committee chair for that appropriations, most likely, and the kind of nuances with that, it's probably going to be the staffer. So I know sometimes it can feel like, and I came here to meet with my, you know, my representative. I voted for you or I didn't vote for you, but you're supposed to meet with me, the people, and you have this person coming to talk to me. But sometimes that can be the best person to speak to. So I wouldn't be discouraged because you still were able to move your conversation along.
Very true. Yeah, if I'm being transparent, I had that exact feeling. I'm like, oh, you know, I came all the way over here and we're on the Hill, and there was one senator who canceled a meeting the day of, and we were all meeting on Zoom, and it was just like, oh no, but I guess you're right. But just keeping that conversation open and having that voice, I feel like that's what the challenge has been for me.
Yeah, and so that's still a good point as well. Like, how do you keep that conversation going, right? Because, you know, in any relationship, you have to spend time together, get to know each other, those kind of things. You're not taking your legislator out for coffee because for the most part, you don't have time for that. But that kind of goes back to what I was saying for the MDS, or Medical Society of Delaware, when they have those meetings where, yes, we can do a meet and greet. Again, Delaware is small. So we can do those kind of meet and greets and talk a bit more about the different bills that affect us. And it's just a tad bit different. You know, I'm from Delaware, I'm a Delawarean, so I can say this affectionately. You can be a big fish in a small pond because it's so small. So again, these are kind of things to think about, because if I want to talk to my legislature, I really can just call them up. Now, partly because it's Delaware and it's small, and, you know, I'm in other organizations as well that kind of give me a different platform, but it's very possible. And I think, oh, I almost forgot about this. I think this is a good point to share too, because it does highlight Delaware. So I'm a member of the Medical Society of Delaware, if you haven't been able to tell already. But as a resident, and this was during my intern year, this was the first meeting I'd ever gone to for the Medical Society of Delaware. And there were a lot of physicians there. And this was kind of around that time for that primary care bill that it ended up being, but this is when we were talking about it. So again, think, you know, Medical Society of Delaware represents all physicians. So this is where we have the specialists coming and talking as well, the GI, the, you know, OB, the pediatrician, all of us talking about this primary care spending bill. And so that is where there were a lot of conversations of, yes, I'm for it because, as one OB said, I'm tired of prescribing hydralazine. I shouldn't be prescribing it to a 50-year-old patient. Like, I'm not a cardiologist. So his perspective, he was very much for it. But then there were some others, one being a gastroenterologist, who didn't want that to happen because he, I don't know, his dream of colonoscopies and what he was thinking was that if we paid more to primary care physicians, there would be more primary care physicians doing colonoscopies and he would lose some of his funding. I'm not entirely sure how logic was going with that, but he was not for it. Either way. So listening to all these people have this conversation, and again, this is my intern year, this is my first meeting there, and they started talking about, well, what do the young physicians of the state, how do they feel? We need more young physicians in the group. So I looked around and I thought, well, I'm a young physician, so they must mean me. I guess I should say something. And so I did. I stood up and I said, you know, sincerely, that it was a little alarming that so many primary care physicians were retiring. It made me feel like I must have chosen the wrong profession. If so many people, this is something I've worked for so long to be a part of, and so many people are retiring or doing concierge medicine, is this something I need to continue? Now, I was just speaking from the heart for how I felt, but that conversation led to a legislator who was there saying, oh, I want to speak to you to hear more about your opinion and your thoughts. Can you work with us? What can we do to keep young physicians in the state? Student loans. So that, again, that led to a different conversation of a way to kind of go back to something that, as you should be able to tell by now, is near and dear to my heart, student loans. So that kind of led to that kind of conversation. And I think part of that is because, you know, big fish in a small pond, number one. And number two, you then follow up. So it's not that every time you think about them, you just say, oh, I'm going to shoot you an email. No, but if something comes up that I think is relevant, or I know they're about to pass a bill or legislation that affects student loans, or they have something that would help compel employers to pay towards the student loan and not make you have to work for 1 to 3 years before you can get any of the money, if this can be part of our package that we do up front, what are some of the ways that we can keep young people, young physicians in the state, right? So it kind of leads to a different conversation, but you kind of stay abreast of these things so that then, yes, part of that relationship is, thank you for supporting this legislation, or I know this legislation is up for discussion. This is how I think it would affect us. That's how you keep that relationship going.
So I got excited, Dr. Samuels, when you said big fish in a little pond, because I was waiting to say that.
Yes, but it's true. It's
But
true.
it is, I know I get that a lot of Delawareans don't like when I say it, but I speak to that as well. Not even on the clinician side, but just as someone in the community, right? Wanting to reach out to your legislator and get a problem fixed. I know that I can contact the mayor or any one of the legislators and have a conversation with them. Like it's not really, I think Delaware is unique in that I come from New York, it's the big city. So Dr. Samuels can attest to this, I'm sure, but like, you know, you email your representative there, you'll be lucky if you get a response, if even from the staffer, you know what I mean? Because they're just so busy or doing so much. Whatever the reason is, I feel like you get a more of a response or even a faster response when you're here in Delaware because of that reason. You can be a big fish in a little pond here. You know, it's not, I guess, as busy or big as New York. Everyone knows each other here. There's some kind of connection to somebody here. It's easy to make connections. I know, you know, as Dr. Samuels is like, you just have to, you know, make relationships and do that. And sometimes it's not easy for people, especially when you're an introvert. But it's easy here because you're just in contact with people, and even if you just go out to, you know, your local restaurant or whatever, some fair that they're having here, you're meeting somebody, if not somebody of importance that can handle something for you, because this is just that type of community. So I did want to speak to that, that you could make stuff happen. Can't promise. Dr. Samuels can give you more of a timeline on how things can get done. Can't promise that it's going to happen, you know, right during your residency or, you know, a year from whenever you start your project, but like you'll definitely start the conversation where things will get the ball rolling, and I think move a lot faster than most places that you'll find. Any other questions or comments?
In addition to the project that residents like choose to work on, do you notice that your residents also kind of have their hands in like all other different like forms of advocacy, or is it mainly like streamlined with what their project is? Because I find myself getting interested in all different things. Sometimes I have to reel it back, but you know, I'm wondering if they have like a few different projects, but in addition to, you know, their main one.
So I think I would say yes. Again, so one thing which is an important caveat is for most of them, COVID, right? So contact with the outside world has been a little challenging. So we haven't had community fairs and things like that, in large part because of COVID and the restrictions that rightfully so the hospital system has placed on those type of sanctioned gatherings, right? So that's been one thing. But as those restrictions have lessened and loosened a little bit, so we do have one resident who's really interested in sports medicine. So she was able to work with the orthopedic sports medicine, and they were talking about things. He works with one of the local universities. He's their team doctor, and she got the idea of, oh, we should do sports physicals at the clinic. This would, you know, give her a chance to help her resume, her CV, right, for when she tries to apply for sports fellowships, to say she led this fair. So that's one piece. But then also too, it helps to get the name out in the community that, oh, for again, those sports physicals, for the pediatric patients that we need, for those young people that we need, hey, we're here as a resource, not just for your sports physical, but all through the year, we're here. Hopefully, if you're able to, again, from a system standpoint, if you're able to say, yes, we would like to make the case for why we should do these sports physicals, because we're able to bring in more young people to establish with us, and then we should be able to reduce by X amount the amount of young people who go to the ER or the urgent care for, you know, random ankle sprain or something like that, that we could see them here in the clinic, right? That's kind of generate more revenue into the clinic, even though we started out with a free service, but look at the revenue generating that we're able to have. So you can see how with that one idea that can kind of meet different people's needs as well. So there's that piece to where there are a lot of residents who are really interested in community fairs and wanting to push that a bit further. So as COVID restrictions are loosening and tightening and kind of waxing and waning, we've been able to do a little bit more. So that sports physical day was not part of her research. That was just something she was interested in doing. So, and we're supportive of that, obviously. So yeah.
I saw photos of that on the social media, actually, with the sports clinic day.
Yeah, yeah, yeah. We thought it was a good success.
Yeah.
And thank you for following us on social media too.
I was going to say that.
I happen to live under a rock. I do not have any social media, but I heard the pictures look wonderful.
I just wanted to say that thank you for sharing on the advocacy in the community, because it's kind of encouraging. I've not had a lot of experience advocating in this environment. However, what you're highlighted to me is that it's important. Everything you do matters, like even if it's the noticing, paying attention to what is going on around you. That way you see points to advocate for, and then take it the next step. So thank you for highlighting that. Yeah.
Yes, absolutely. Because again, part of that is being the change you want to see, right? To kind of quote, paraphrase Margaret Mead, right? So part of that change that you want to see is also by keeping your eyes open, listening to what your patients are telling you. What are some of their struggles? What are some things that are, you know, concerning to you? They may be concerning to other people as well. So just kind of keeping your eyes and ears open to be receptive really helps.
Thank you.
Going off of that, this isn't really a question, it's more just a comment, but I feel like I used to have a very narrow idea of what advocacy would look like, specifically more like a legislature side. I thought that's like, but I think everything, Dr. Samuels, that you were saying is a really good representation of all the different ways you can advocate, and it's not necessarily just legislature. And Yeah, I just thought it was a really good description of all that. And then maybe, I think I would have liked to hear that coming in as a first year med student. So.
No, it's good. I mean, I understand, you know, in the beginning, because that's, in a lot of ways, that's all you see, right? Is that, oh, some lobbyists came through and they made a new law, and then, you know, how you feel about lobbyists. But, you know, I'm advocating for something. I'm not paid to do it in the way a lobbyist is, but there might be a few other nuanced differences. But truly, I'm speaking on behalf of others, right? I'm not paid to do it, but I'm speaking on behalf of others and trying to get our best interests done, really, and trying to be the change you want to see type of thing, and trying to make their lives better. Because you know, yes, of course, I want to help your blood pressure, your diabetes, I want to deliver your baby, I want to do all these things. But I also want you to have a good experience. So in terms of delivering your baby, great. We know that in terms of pain in labor, that if you have someone dedicated to you as the laboring patient, you tend to do better. You're able to prevent that primary C-section, right? So then if we say, okay, let's take a step back, who are the people? Is it just anybody? Is it any just random person walking down the hallway? Does it have to be your significant other? Should it be a doula? How can we increase, you know, or rather reduce maternal morbidity and mortality? Okay, if it is involving someone dedicated and specific to the laboring patient, then what can I do to help with those efforts to bring doulas into the room? So with COVID, you know, in the beginning, and they were saying you can only have one support person. Well, I mean, I'm sure the significant other, you know, mostly, not always, father of the baby or significant other, rather, to be more broadly, wants to be present. But if that patient also wants to have a support person as a doula, why can't that person be involved too? They're part of that medical team in that way. How can I advocate on behalf of my patient so that she, you know, or the laboring patient has what she needs to kind of have someone to help her? Okay, can we change this rule so it's not just one person? It can be a doula and a significant other, and at least two people can be present in the room. You know, what if somebody's doula is their mom or something else? But that's fine. But how can I help advocate for my patients in that what seemingly is a small way, but that is really helping that patient have someone there for her? Because I know I'm not going to be in the room the whole time, right? So it can be as broad as you want it to be. Again, that kind of goes back to that having your eyes open, your ears open to say, well, what is the need and how can I try to fill it? I know it's almost 9 o'clock, so I don't want you all to feel like you're being held captive here on this Zoom meeting. It is a random, what is it, Wednesday, Thursday? Thursday, oh, thank you. I'm also on PTO, so.
I do think we're
Well, I'm inspired.
just about at the hour, and I think this was really exciting and wonderful to hear, Dr. Samuels, you talk about the program, and Stephanie, thank you. And thanks everyone for joining. I don't know, Dr. Samuels, do you have any other final thoughts before we sign off?
No, I mean, really, I do appreciate you all taking the time, you know, on a Thursday, thank you, Stephanie, to listen, to hear about our program, like Scott was saying as well, and just hearing what we think makes us unique. But again, Delaware is a small place. It's you know, you can be a big fish in a small pond, so definitely consider us, especially having a chance to really get your voice out there and knowing that you'll be in a supportive environment to do so.
Well, thanks everyone, and have a great rest of the night.
Thank you.